We're going to do something pretty ambitious in this lecture. We're going to go over all of the high-yield treatment styles that you're going to see in the clinic and while you're reading your textbooks. The purpose of this lecture is to give you an idea of all of the treatment styles and what makes them similar or different to one another. This lecture is also going to help you choose which treatment style you want to use for which sort of patient. This lecture is going to be a little bit longer, but it's set up like this on purpose so that we can go over everything all at once. During this lecture, the high-yield points that you should pay particular attention to are which treatments are direct, indirect, active, and passive. So to start off with, we're going to go over some quick vocabulary. So you can have an active treatment, means that the patient assists in the treatment, meaning that at some point during an active treatment, you are going to ask the patient to do some sort of motion. A passive treatment is going to be the opposite. During a passive treatment, we're going to ask the patient just to remain completely still. At no point during the treatment do we ask the patient to do anything. There are two different types of treatment, and the first one is direct. A direct treatment is a treatment that directly engages the restrictive barrier. So remember from the previous videos, we were talking about how you always name a diagnosis based off what it can do. So the name of the diagnosis is the freedom. So the barrier is what they cannot do. So it's going to be the restriction. It's going to be the opposite of the freedom. So if the diagnosis is something like T6, flexed, rotated, and side bending to the right, the barrier is going to be extended, rotating, and side bending to the left. It's going to be the opposite. An indirect treatment is going to be the opposite. Instead of engaging the barrier like we did for a direct treatment, we're going to engage the freedom, or what the patient can do. So why would you choose a direct treatment or an indirect treatment? It's going to depend on what sort of patient you see and what sort of dysfunction that they have. So a typical patient that you will choose a direct treatment for would be someone who's younger, who does not have too much pain during motion, and maybe even a dysfunction that's chronic. When you're doing a direct treatment, you're going to be engaging the barrier, or what they can't do. Sometimes this is a little bit painful or uncomfortable for the patient. If it's painful, then you're going to do something that's indirect. But if it's not painful, you can stick to direct. So indirect is going to be the opposite. You're going to do this for someone that may be older, who has pain with the dysfunction, and maybe something that's a little bit more acute. So if you think of an acute dysfunction, when it first happens, it may be a little bit more painful than after you've been sitting on it for a while. So acute and painful, think indirect. Chronic, no pain, think of a direct treatment. So for the rest of this, we're going to go with one example, and I'm going to relate all of the treatments back to it so that you understand the barrier, the restriction, the freedom, all the vocabulary. So let's say that the dysfunction is going to be T7 FRS right. So you always name it by what it can do. So T7 can flex, can rotate to the right, and can side bend to the right. This is the freedom. The opposite is what they cannot do, the restrictive barrier. So as I'm going through these examples, keep in mind direct, indirect, active, passive, barrier, freedom. So the first treatment style is going to be muscle energy. When I say muscle energy, what I want you to think of is isometric contraction. I want you to think of lengthening the muscle to engage the restrictive barrier, and then an isometric contraction into the freedom that will then shorten the muscle. It'll make sense as I write this out. So there are two flavors of muscle energy. The first one is post-isometric relaxation. This is going to be a direct technique and also active. So this means that we are going to engage the barrier during treatment, and we're going to ask the patient to move during the treatment and help us with the treatment. When you hear muscle energy, I want you to think of the Golgi tendon organ. Without getting deep into the Golgi tendon organ, it basically boils down to this. The Golgi tendon organ recognizes that there is extra tension during treatment. It's going to tell the agonist muscle to relax, which is then going to allow the physician to move further into the barrier. So if you hear muscle energy, think Golgi tendon organ. So how do I set up and perform this treatment? The first step is you are going to passively move the patient into the barrier. So the first step of the treatment is going to have the patient seated and relaxed so he is passive. You need to move him into the barrier. The barrier is what they cannot do. So if they can flex, rotate right, side bend right, they cannot extend, rotate left, side bend left. So the barrier is what they cannot do. The diagnosis is what they can do. Make sure you keep that straight. Once they are into the barrier, this is where you're going to ask the patient to assist during the treatment. You're going to have the patient actively, isometrically contract to the freedom. So you have the patient engaged in the barrier already. You're going to ask the patient to move into the freedom. So move into the diagnosis. Move into what they can do, which is flex, rotation right, side bend right. Remember from the previous lectures, we talked about what an isometric force is. So they're going to try and move in towards the freedom, but during treatment, you are going to hold them still and give them enough of a muscle force that keeps them in their position. So that's isometric. The patient pushes while the physician pushes. Both forces cancel each other out and there's no motion. Once that they actively move into the freedom for 3 to 5 seconds, you are then going to passively re-engage the new barrier. So this is going to be the same barrier as before, but it's the new barrier since you can now go further into the barrier because of the Golgi tendon organ telling the agonist muscle to relax. So new barrier, what they can't do, extended, rotate left, side bend left. The next step is going to repeat everything 3 to 5 times. Once that you've performed the entire treatment 3 to 5 times, you can then bring the patient passively back to neutral and rescreen. At the end of every single treatment, whether it's muscle energy or anything else that we discuss, you have to rescreen and make sure that your treatment worked. So rescreen at the end of everything. So I said muscle energy comes in 2 flavors. You have post-isometric and reciprocal inhibition. This treatment style is going to be direct or indirect. But it will always be active. So direct or indirect either engages the barrier or engages the freedom. You'll see the difference during setup. So if it's a direct treatment, you want to put the patient into the barrier during setup. So what's an example of this? The easiest way to think of reciprocal inhibition is going to be your biceps and your triceps. Your biceps will be the agonist muscle and the dysfunctional muscle, and your triceps will be the antagonist. So imagine that the patient has an hypertonic biceps, meaning that they can go into flexion, but they cannot go into extension. So if I'm going to directly engage the barrier, I'm going to ask the patient to do what they cannot do, which is go into the extension barrier. And then I'm going to have the patient contract their antagonist muscle, their triceps. If I want this to be an indirect treatment, I'm going to place the patient into what they can do, which is flexion. And then I'm going to ask them to engage their antagonist muscle, which is their triceps. So in reciprocal inhibition, you're always wanting to engage the antagonist muscle. In post-isometric relaxation, your goal is to engage the agonist muscle. So for our example of a hypertonic bicep, if we want to directly engage the end barrier, we're going to extend the bicep and flex the tricep. If I want this to be an indirect treatment, I'm going to place the patient into what they can do, which is a flexed bicep, and I'm still going to ask them to flex the tricep. Once you've done the treatment, you then put the patient back into neutral and rescreen. So the next treatment style is going to be high velocity, low amplitude, or HVLA. Whenever we think about HVLA, think of the technique that causes the pops. So when we're talking about HVLA, think of popping and cracking. So HVLA. This type of treatment is going to be direct and passive. So during the treatment setup, we're going to engage the barrier, and it's passive. We're not going to ask the patient to do anything. So the first step in this treatment is going to be passive motion into the barrier. So relating this back to our example, the patient's diagnosis is T7, flexed, rotated right, side bent right. This is what they can do. This is the freedom. So if we want to engage the barrier, we engage the opposite. So we'll want to engage extension, rotation left, side bending left. So the first step, passive to the barrier. The next step is to instruct the patient to relax, which mostly includes breathing techniques for them to relax. When you're trying to thrust through the barrier, it's a little bit easier when the patient is relaxed and their muscles aren't tense. Once you have the patient relax, then you are going to perform your HVLA thrust through the barrier. So we already have the patient in the barrier, which is extension, rotating left, side bending left. So the HVLA thrust goes through the barrier. So your thrust will further push them into extension, rotation left, side bending left. This thrust is what's going to cause your pop. After the treatment, bring them back to neutral and rescreen. So the next treatment style is facilitated positional release, or FPR. This treatment style is going to be a little bit different than muscle energy and HVLA. It's going to be indirect and passive. So this treatment is indirect. What we've previously been talking about is direct. So instead of engaging the barrier like we did for muscle energy and HVLA, we're going to set the patient up into the freedom first. So the first step is going to be passively moving the patient into the freedom. So for our example, T7 can flex, can rotate to the right, can side bend to the right. So we're going to passively move them into what they can do. So flexed, rotated right, side bent right. They're now into the freedom. The next step is going to add an activating force. So what's an activating force? When you're performing your treatment, you just add compression down to the segment of dysfunction. So that can be from the head and neck, or that can be from the shoulders for any of the dysfunctions lower down the spine. So you add the compression force next. In this example, T7 is dysfunctional, so you need to make sure that your compression force goes down to T7 for the treatment. Once that you add the activating force, you are then going to passively move the patient further into the freedom. So you're going to put the patient into the freedom, what they can do. You add the activating force. With the activating force, you push them further into the freedom. So add the activating force, push them further into flexion, rotation to the right, and side bending to the right. Once that you do that, the treatment's been complete. So now you can passively return them back to neutral and then rescreen. So you release your force, return to neutral, and always rescreen. The next treatment style is going to be balanced ligamentous tension, or BLT. This treatment is going to be similar to FPR in that it's an indirect technique. So this treatment is indirect and passive. So like FPR, where it's indirect, but not like muscle energy or HVLA, that's direct. So for BLT, indirect, engage the freedom. The next step that you're going to do is engage the freedom in 3 planes of motion. So think about 3 planes of motion of the diagnosis. You have flexion extension, rotation, and side bending. You want to engage the freedom, or what makes the tissues all neutral during your first step of the treatment. So indirect, what they can do, first step is passive on 3 planes. Once they're in the freedom for the 3 planes of motion, the next thing that you do is just hold and wait for the release. Once that you feel the release or the softening of the tissues, you then bring them back to neutral and rescreen. So again, with our treatment example, T7 is flexed, rotated right, side bent right. The 3 planes of motion that you're going to engage: flexion, rotation right, side bending right, into the freedom. Hold it there until you feel a release. Once that you do, neutral and rescreen. The next treatment is going to be still technique. Now still is going to be a little bit different. It's both direct and indirect. As well as being a passive treatment. So during this treatment, you're going to engage both the direct barrier, or what they cannot do, and the indirect barrier, or the freedom, what they can do, what the diagnosis is. So the first step of the treatment is going to be to passively move the patient into the freedom. So for our example, T7, they can flex, rotate right, side bent right, put them into the freedom, so put them into flex, rotate right, side bent right. The next step is going to be to add an activating force. Once that you have the activating force applied, this is where the direct portion of the treatment will begin. You add the activating force, and then you move the patient into the direct barrier. So in this treatment so far, you have the patient what they can do: flexed, rotate right, side bent right. You add the activating force, and then you move the patient further into the barrier, or what they cannot do, which will be extension, rotation left, side bending left. So now passive through barrier. Once there, you can then release your activating force, bring the patient back to neutral, and then you rescreen. Always rescreen. So up until now, all of the treatment styles that we've talked about, I want you to think of using when you're treating something in the spine or some sort of a joint. The next 3 treatment styles that we're going to go over, I want you to think about treating a muscular dysfunction instead of treating a spinal dysfunction. So think muscle for the next 3. This next one is going to be counter strain. So counter strain is a indirect treatment that is also passive. Now we have a whole video devoted strictly to counter strain that comes on later in the series. But for right now, I want you to think of indirect treatment that's also passive. So if you're doing an indirect treatment, you put the dysfunction where it can go. If it's a hypertonic muscle, what it can do is bring the 2 ends of the muscle closer together. So for a counter strain treatment, your whole goal is to bring the 2 ends of the muscle closer together. We're going to do this by folding and holding, or just shortening the muscle however we can. So when you think of counter strain, think of fold and hold, which will shorten the muscle. The next treatment style is just going to be stretching. Now imagine stretch as just being the opposite of counter strain. It's going to be a direct treatment. The whole goal is to elongate the muscle. So you're going to take the attachment and the origin and take them further apart by stretching the muscle. This can be accomplished by doing the opposite of whatever the muscle usually does. For example, if the bicep normally flexes, if I'm trying to stretch it, I'm going to do the opposite. I'm going to extend it. So a stretch is direct and passive. Your whole goal is to elongate the muscle. And this last treatment is really just about anything that you want it to be. It's myofascial. This can be direct or indirect. It can be active or passive. It all depends on how you set up the patient for treatment and if you're going to ask the patient to assist you or not. So myofascial. This can be direct or indirect. And can be passive or active. In this treatment, you're going to move the muscles around in 3 planes of motion, including traction, rotation, and compression. For a more in-depth example, look later on in the series at the lumbar lecture. So how are we going to make this direct or indirect? It's easy. You either engage the barrier or you engage the freedom. So 3 planes of motion, which include traction, rotation, and compression. Direct to the barrier, or where the tissues cannot go, and indirect into the freedom. So when you're performing this technique and you're putting the patient directly into the barrier, you're going to put the tissue where it doesn't want to go. When you're pushing in that direction, you're going to have a hard in feel. It's going to feel very taut when you move that way. Indirect, you engage the freedom. When you move the tissues in that direction, it softens or loosens. So how do you make this treatment active or passive? This is where you use enhancers. So what's an enhancer? An enhancer is during your myofascial treatment, you ask the patient to contract whatever muscle you're treating. So for example, let's say you're doing myofascial to the diaphragm. You're doming it and pushing your fingers into the diaphragm. If you want them to contract, you can have them actively help you in treatment by deep inhaling and deep exhaling. This movement is going to make the treatment active, and it's an enhancer. So enhancers make the treatment active. So these are all of the treatment styles that we're going to go over. You have muscle energy, where you think of post-isometric relaxation and reciprocal inhibition. Always think of isometric contraction. HVLA, think of the popping. FPR, where it's all indirect. BLT, where you have the 3 planes of motion. Still technique, where it's both direct and indirect. Move on to the muscular treatments. You have counter strain, which is fold and hold. Stretching, which is elongating the muscle. And myofascial, which is really the grab bag of everything. So the important part of this is that you understand the concepts of direct, indirect, active, and passive. So we're going to make a big chart with everything. So we have muscle energy, HVLA, FPR, BLT, still, counter strain, stretch, and myofascial. And each treatment can either be direct, indirect, passive, or active. So what about muscle energy? Direct, indirect, active, or passive? When you think muscle energy, think of it being direct, but also know that occasionally it can be indirect. This is an active treatment because the patient is actively helping you. He's doing some sort of muscle contraction. When you think of HVLA, it's direct. You directly engage the barrier. The treatment is passive because the patient relaxes. The patient doesn't do anything. FPR is indirect, where you engage the freedom, and it's passive because the patient does not help you during treatment. BLT is the same, where it's all indirect, and it's a passive treatment. Still is the weird one, where it's both direct and indirect. Although when you're thinking of still technique, in the clinic or on an exam or wherever else, think of still as being an indirect technique, but just know that it's both. So if you get asked to do an indirect technique and still is an option, think of indirect still technique. This technique is also passive, he doesn't help. Counterstrain is going to be indirect, where you engage the freedom and you shorten the muscle, and it's going to be passive, where the patient does not help you. A stretch, you're elongating the muscle and doing what it cannot do. That's going to be direct, and it's going to be passive because the patient is not going to help. In myofascial, everything, depending on however you set it up. So it's direct, indirect, passive, or if you want to use enhancers, active. Now, one final quick thought is treatment sequencing. When you're treating something, you always want to think of sequencing by starting centrally and working your way out peripherally. So just as an example, if I want to treat something in the hand and I'm thinking of sequencing, start in the thoracic area, then move out to the shoulder, then upper extremity, then your hand, distal dysfunction. You want to do this in order to make sure that you hit all of the compensatory patterns along the way. So if you get asked about sequencing, think central, work out peripheral. So to sum up everything in this massive lecture, we talked about all of the high-yield treatment styles. We discussed active, passive, direct, and indirect, which are your main things that you have to know about each treatment. Why you would use direct or indirect. We went through examples with all of them, and then we also did a chart that has everything that's super high yield. And that's OMM treatment techniques.